Hi folks, Phil Russo here and welcome to Infection Control Matters, my first episode for 2026, so welcome to everybody. I'm joined by Brett Mitchell. Good to see you, Brett.
Good day, Phil. Hi, everyone.
And I'm also joined by our guest speaker, who is Dr Lyn-Li Lim. Lyn-Li is a infectious diseases physician who works in Melbourne, Australia, and also works at the VICNISS Coordinating Centre. Lyn-Li also dabbles in some public health and epidemiology and antimicrobial stewardship. So welcome, Lyn-Li.
Hello, and thank you very much for inviting me.
You're welcome, Lyn-Li. I'll get to the article shortly that we're going to speak to, but perhaps you could just tell us a little bit about yourself and what you do and what VICNISS does.
Yep, happy to. As you said, I'm an infectious diseases physician. At VICNISS, we're kind of a team. We're responsible for coordinating healthcare-associated infection surveillance for Victoria. And so public and private hospitals are involved with reporting. So we receive and report out data on surgical site infections, CLABSIs, Staph aureus bacteremia, and also healthcare worker influenza vaccination, for example, as a suite of things that we do. But as part of our role, we also have pretty close links with IPC programs and hospitals, based in hospitals around Victoria. And so we felt that that put us in kind of a good place to reach out to kind of start this work, which is based on resourcing of IPC programs.
So the VICNISS is the group that the IPCs have to report a lot of data to, and maybe sometimes they might say things like, we don't have enough staff to get that data to you in time, or our resources are stretched at the moment. So which brings me to the article that's just being published in the American Journal of Infection Control, and it's titled Resourcing of Hospital Infection Prevention and Control Programs in Victoria, Australia. And you're the lead author. And essentially, overall, high level, it's a bit of a snapshot of the current resources that we have in Victoria for IPCs. So, Lyn-Li, perhaps you could just start off by telling us about the aims of the study and how you went about it.
It was pretty simple, really, to provide a current snapshot of hospital IPC program staffing in Victoria, Australia. Most of us may be aware, but for those internationally, Victoria is the second largest jurisdiction in Australia by population. And we have a structure where we both got public and private hospital systems, both of which, report to VICNISS. And why we felt that a current snapshot would be useful is in Australia, there are no real consensus recommendations regarding IPC program staffing requirements. And there's also been very little published information on resourcing of IPC programs in Australian settings. So we felt that, this piece of work would kind of put a contemporaneous snapshot. A lot has changed with time. So we thought that this would be of value both in Australia and internationally. And how we went about doing it is we sent out a survey to the IPC program leads that are involved in running hospital programs and asked them a number of questions based on their resourcing and also what other supports that they had in place to support their program. So we then, looked at the data, and this survey was done in July 2024. And then we subsequently felt that it was useful to look at the results by whether these hospitals/facilities were public or private, whether they were located in metropolitan or regional rural areas, and also by acute bed size, because that was the main metric that we decided to use to report out on adequacy of resourcing.
Sure. Before we get to the results, Lyn-Li, I noticed in the aim it was stated that one of the reasons you were doing the study was to advocate for IPC resourcing. So does this sort of imply that you know, or you sense, or you are informed by the hospitals that they're understaffed or under-resourced?
Yeah, as You mentioned before at VICNISS, we do get calls. We get frequent contacts from IPC programs and hospitals, so we get kind of probably a real-time sense of the pressures that they're under. I mean, obviously, their contact with us is where it's impact on their surveillance reporting. If they can't meet timelines, etc. But we also get a feel for the reasons why. And, it's certainly clear to me and VICNISS, I think, that the workload and responsibilities have evolved over time in terms of what's expected from IPC teams. And so having an understanding of what sort of resourcing is required, well, we need to start at actually how they're resourced in the first place. Yeah.
Just before we get to the results, could I just ask, Lyn-Li, one of the challenges when looking at this, I've done a fair bit of work of this about 10 years ago in this space, and one of the challenges we came across was what you include in both the numerator and denominator data by way of FTEs, if you're looking at FTEs. And I wondered, before we get to the results, did you include things like contracted staff, hand hygiene auditing, link nurses, or relative sort of similar positions, or environmental service staff that were actually part of the IPC unit? What did you define as IPC professionals to be included in your numerator?
Yeah. So what we asked them to report on was in terms of payroll, who's on the payroll at this point in time. If they're on the payroll, then, it's under the IPC program, then that's who they include, accepting the limitations, as you pointed out. People are contracted to come in, like, if there's annual flu program, etc., people will come in and out. The other thing that we did collect data on, but not in a quantitative way, but in a qualitative way, is actually ask them what sort of professional groups are in your IPC team. So is it just nurses, or are there doctors or epidemiologists or admin staff? And if so, if they are on the payroll for the IPC program, what EFT they had.
It's probably worth mentioning also that the Australian standards for safety and quality in healthcare do have a standard for infection prevention, and they do say that hospitals should have an infection control program appropriately staffed by an infection control team, but they don't actually go any further than that. It's very vague or grey as to what comprises an infection control team.
I can't understand why, though. I mean, to be very prescriptive has some advantages, right? So you have the advantage of having, at least we can meet this minimum requirement, or at least we can say that we've got X amount of resources. But it's challenging because the health services are so different. Some will have outreach services into mental health, into community settings that aren't captured by some kind of denominator like overnight bed days. And the complexity of hospitals and the program that you may deliver will not be consistent across different hospitals for various reasons, and probably rightly so. And even within your hospital, it's probably going to be consistent or inconsistent over time for various reasons, including needing to respond to certain demands or issues that might arise. So, I'd love to see something a little bit more out there in this space personally, but one of the reasons several years ago when we tried to do this, we couldn't do it, was because of some of those reasons. And some hospitals actually felt that if you set a number for those hospitals that exceeded that number, they would go, oh, well, you don't need as many as what you've got. And that might particularly be harmful for complex or complicated programs or services with IPC. So I know, I can kind of understand why there isn't something a lot more prescriptive in accreditation, but then it makes it hard for that kind of work to be done. But equally helpful when you have Lyn-Li's work to be able to provide up-to-date information on, well, what does the state of play look like, so that you've at least got some idea as to whether you're in the ballpark or not. So I think that's, for me, before we get the results, that's one of the values of doing this type of work, and particularly having contemporary data on these types of things. It just allows you to know, am I my finger on the pulse, or am I way off here?
Yeah. The scope of the role is variable, isn't it? And I think, particularly when it comes to things like occ health and staff health, that sort of stuff. But we'll come to that. So perhaps, Lyn-Li, I'll come back to you. And do you want to give us the high level, the main findings from the study?
Yeah, as I mentioned before, the data that we got on resourcing, we kind of analyzed it by size, sector. And so our key findings were that large hospitals, by large hospitals, we kind of like classified hospitals by less than 50 acute beds, and then we had a category kind of 50 to 99 acute beds, 100 to 200 acute beds, and then more than 200 acute beds. So that's how we define large, more than 200 acute beds. These hospitals, these large hospitals, had a higher median consistently across the board, higher median FTE per 100 acute beds for IPC program resourcing than hospitals in the categories 50 to 199. And it was a pretty big gap. The other key finding that I think, you mentioned the paper that you were involved in 10 years ago, Brett, this finding of that public hospitals had a higher median FTE than private, and it was actually a big difference. That was something I think you identified in your paper 10 years ago. And what we found that this was a really big difference. And we tried to kind of remove confounders further by just drilling down to, let's say, if you're a large hospital, let's compare public versus private, because if you're a large hospital, you're more likely to have ICU, ED, patient complexity. What we found, that finding of that big gap in difference in median FTE actually held. We also did find that the hospitals in public versus private had generally IPC nursing staff that had a longer time spent working in IPC programs. So not novices, like, less than 12 months working in an IPC role, but longer than that. So, 1 to 5 years or more than 5 years, there was a big difference in private versus public. So I think those were probably the big picture key findings. We've already touched on the fact that, there is no ideal metric, because if there was an ideal metric, then we can be perhaps a bit more prescriptive about, what's ideal. What we did find that using kind of FTE per 100 acute beds really didn't work for the very small hospitals. So that's the hospitals with less than 50 acute beds. And it didn't work because in Victoria, most of these very small hospitals are rural regional. They tend to have one person in the IPC role often, and that person wears a hat. So, they're responsible for a massive portfolio. They're often also responsible for long-term care beds that might be, closely linked to the public hospital. So we found that that metric just really didn't work at all for that group. So that's a cautionary tale to bear in mind.
So just to be clear, so this is the actual hospital itself that responded, not the health service, because the health
Correct.
services,
Yeah.
some health services will have several hospitals, but you
Correct.
actually got a response from each of the individual.
Correct. So our denominator in terms of survey respondents was the IPC lead in that hospital. And if they were responsible for multiple hospitals in their organization, they could respond to the survey multiple times, but only at a hospital. Yeah, correct.
Good way to do it. It's an interesting finding, Lyn-Li, about the difference between public and private, and the fact that that's held true for some time, and how you explored it was a good way to do that too. And going back to your point, Bill, about prescription and accreditation, if you're an accreditor perhaps and you're going to a private hospital, would it be worth asking the question, why is your staffing so low compared to the public hospitals? What's the justification for that? What is the fundamental difference in your service compared to someone else? Because it'd be a good question to ask, not to put the screws on the infection control team, but rather the screws on the private hospital management about their support or potential lack of support, if that's indeed what this finding's inferring, in terms of resourcing support, that is, for IPCs in private hospitals. So I think that's a really interesting finding, that difference is stark, and it's been consistent over time.
Yeah. And so what we're talking about is an FTE of 3.2 per 100 beds in public sector hospitals versus 0.4 FTE per 100 beds in the private sector is what this data demonstrates. Now, the other interesting finding along those veins, I thought also, Lyn-Li, was it the large public hospitals were the only sites that had non-nursing IPC staff?
Yeah, yeah. And that kind of doesn't surprise me a whole lot. That would probably reflect my experience of working in Victoria. But obviously we go back to the, initial work, like the scenic study, a few decades ago. They set up that ideal scenario, which is to say, like, how you make the biggest difference in terms of reducing healthcare associated infections is the IPC team, should have various, nurses, but also, epidemiologists and medical involved. That's obviously not the case at the state of play currently in terms of what our survey shows. But obviously, I think the larger public hospitals, some of them have a little bit more resourcing to support this. Just going back to, I guess, the difference between private and public and why there might be, like, another question that we asked in the survey is whether they use outsourced IPC. Right, because we would understand that might kind of reflect on FTE, like people on a payroll, and there was a difference in the use of outsourced IPC in private versus public. So there was about 60% of private hospitals use outsourced IPC versus about 10% in public. We did ask whether is outsourced IPC all they used, or did it support IPC program? And for the majority, actually, it supported the existing IPC program in the hospital.
I wondered whether you asked about what people were doing in their role. I mean, in previous work, I think it was 40-50% of the time people were spending on surveillance. And of course, surveillance can be very time consuming, or maybe less time consuming if you've got some kind of automation or system that will help with that. And of course, Victoria, you might want to describe that. But I guess at least that's one variable that's probably going to be consistent across your cohort. And I just wondered for a minute whether any of those differences could be explained by people's roles, what they're doing or what they're spending time on, or perhaps not.
We did ask that question and how we asked it was, what's under your IPC program umbrella, what are you directly responsible for? So, hand hygiene, occupational exposure, healthcare worker flu vax, surveillance, and what sort of surveillance do you do? So it was kind of really hard to clearly, I would love to come in and say, well, it's because, all of that is outsourced, staff health is outsourced. Yeah. I don't think it's as simple as that.
Yeah. And in terms of surveillance for the audience, do you have any automation for surveillance in Victoria?
At VICNISS, we've done a little bit of work around that separate to this, but in this particular project, we did ask the very specific question about whether their hospital had electronic health records, or EMRs, electronic medical records, in place, because we would know that just even being able to find the information consistently in one place with a single source of truth is so helpful with surveillance, by and large, and it reduces the manual workload. And it was really interesting. I must say I was really quite surprised. In public hospitals that responded, 53% said that they had an EMR in place, so implemented. And in private hospitals, it was 3%. Now, of course, we would understand that the EMR is not the be-all, and you can actually get information required for surveillance from other kind of electronic sources. But yeah, that I must say, those percentages did kind of surprise me.
That is a stark difference, 3% versus 53% for EHRs. Yeah, 2024 the survey was, so that proportion might have changed a little bit by now, but it's probably much the same, isn't it?
I was going to say, one of the findings, I think, and correct me if I'm wrong, please, is what you report by way of FTE per 100 beds, and perhaps just that large hospital was reported as 1.6 FTEs per 100 beds, and previous studies in Australia have suggested about 0.6 was the average. That's quite a big difference. I wonder if you had any thoughts as to why the FTE is so much higher in Victoria reported in this study compared to
Yeah.
previously?
That's a really good question. So it was a really big range. It ranged from 0.1 to 3.4 in terms of public hospitals greater than 200 beds. It was a really big range. And what we've actually chosen to report out is the median. So, we felt that probably the best way to actually report it out. So I don't know if that kind of...
Huge variance, I guess, is what you're almost inferring.
I'm trying to politely say. Thank you, Brett. I appreciate that.
Well, but that's still useful, because that's an important point, because again, we talked about what's the purpose of doing this, and understanding where you might sit in. If you're at the low of that range, you might be going, hang on, I've got a bit of an argument and case here for trying to get more resources in my hospital.
I suppose the hospitals that participated got their data back that they could compare with other sites?
Well, we sent them a report out as soon as we analyzed the data. So, doing this work is for advocacy, right? It's to help hospitals, but it's also to kind of help us all kind of get to an understanding of where we are. So that's why we think that, we don't want to let this work kind of be fallow. We want it to stimulate discussion. Yes, there might be limitations in terms of how we've reported out the results, but it's a really important discussion to have and to continue to have, to understand, are our hospitals being adequately resourced? I think we would agree that COVID, for better or worse, did expose a lot of gaps in IPC. So I'll be hoping that a lot of organizations and programs would be taking the opportunity to kind of do a stock take of where they are, and are they in a good place to continue to be able to effectively respond to IPC threats in the future. So I think that's what we're hoping, that this work will stimulate that sort of discussion.
I notice you reference the APIC tool, that the calculator for working out FTE. Does VICNISS have a role in helping the IPC people build cases to take to their executives to try and get more resources, or is that something that you don't think you dabble in?
Well, I think one thing I've learned from reading the literature around the APIC calculator is it's taken a lot of work and a lot of testing. It is no easy feat. And I think why it's taken so much work and time, because the intent is that it's a calculator. You put in what resources you have, and then it spits out, this is what you need for what you have to do. But I think just reading the literature around kind of development of that APIC calculator, it strikes me that some of the things that we've talked about here that are difficult to capture, but definitely might have an impact on workload and responsibilities of an IPC team. They're actually pretty difficult to capture, but it does make for interesting reading as to what variables that they've built in there, and I think that's a really good place to learn from.
Okay, well, look, just perhaps the last question before we finish up, Lyn-Li, have you had a chance to present this data back to the funders of hospitals or the private sector area?
VICNISS have written a report to our funders. That's the Department of Health in Victoria. And so we've shared those findings. We're also just working really hard to disseminate these findings far and wide, because I think it really does require a broad advocacy effort to bring about kind of awareness. I'm not saying that there's no awareness, but sort of an effective response.
Broad advocacy or a pandemic, perhaps. But we've had enough of them for the time being.
Oh, Phil, don't say that.
Okay, well, look, we'll leave it there. Lyn-Li, thank you very much for your time. It's always an interesting topic, workforce resources in IPC. Difficult to get good evidence to build cases, isn't it? But I think you've done a good job to paint the picture of where we're at today and perhaps where some of the gaps are. So thank you very much for your work.
It really is. Yeah, well done.
Thank you.
Okay, thanks, Brett, and we'll see you all next time.
Bye for now.